fractures. Let's start with the epidemiology of these injuries. Talar neck fractures are the most common tarsal bone fracture after calcaneal fractures. They comprise between 0.1 and 0.8% of all fractures that are seen. Up to 25% of these injuries are open. And one needs to be careful about associated non-contiguous or systemic trauma, which may delay the diagnosis and the treatment of these injuries. The anatomy of the talus is odd. The overall osteology comprises a head, neck, and body. And on the undersurface of the talus, there are three facets which make up the subtalar joint: the posterior facet, the middle facet, and the anterior facet. More than 60% of the surface area articulates with other bones. The talus has no tendon or muscle attachments. And it has been said that the second hardest bone of the body is the talus, following only the petrosal bone of the skull. The mechanism of the talar neck fracture is a hyperdorsiflexion mechanism of the ankle with concomitant axial load applied. This is usually seen with motor vehicle accidents or falls from height. Historically, the talar neck fracture has been called the aviator's astragalus. This was coined by Anderson in 1919 in a report of a series of 18 fractures in pilots during World War I. These injuries were caused by a hyperdorsiflexion force to the foot by the rudder bar of the aircraft on belly landings. One of the common questions that I get from trainees is, where does the neck begin and the body end? And this differentiation is important in determining whether patients have either talar neck fracture or a talar body fracture. Fractures anterior to the lateral process are talar neck fractures. So in this example, although there is comminution present, all fracture lines are anterior to the lateral process of the talus, and therefore this is a true talar neck fracture. Fractures posterior to the lateral process are talar body fractures. Complications associated with talar neck fractures are non-union, which occur in about 4% of injuries, osteonecrosis, which can occur in up to 20% of injuries, and malunion, which occurs 100% of the time if the talar neck fracture is not reduced and fixated properly. The talar blood supply is crucial to understanding the pathology and healing of many talar pathologies. This is nowhere more true than with talar neck fractures. In this cartoon, the talus is viewed from the medial side, and you can see that there are two arteries supplying the anterior portion and part of the posterior portion of the talus. The first is the dorsalis pedis artery, and the second is the posterior tibial artery. The dorsalis pedis artery gives rise to the lateral tarsal artery, which wraps around the inferolateral portion of the talar neck, as well as some retinacular vessels that supply the dorsal portion of the talus. The posterior tibial artery gives rise to posterior tubercle branches, as well as deltoid branches, and the artery of the tarsal canal, which wraps around the medial aspect of the neck and anastomoses with the lateral tarsal artery to form the inferior portion of the retinacular vessels of the talus. The lateral view shows the dorsalis pedis artery as well as the perforating perineal artery. And there is a lateral tarsal artery that branches between these two and again forms that artery that reflects along the lateral neck of the talus and anastomoses with the blood supply from the medial side to form the inferior retinacular vessels. This artery coming from the lateral side is called the artery of the tarsal sinus. Finally, we'll look at the inferior view of the talus, and here you can see that artery of the tarsal sinus as well as the artery of the tarsal canal joining to form that inferior portion of the anastomotic ring. Osteonecrosis of the talus can be a very serious complication associated with talar neck fractures, and this has been found to occur in up to 20% of talar neck fractures. This rate goes up to 50% with large amounts of comminution or in open injuries. The good news is that many cases of osteonecrosis of the talus are asymptomatic, and 30% of those with AVN go on to collapse. The treatment of osteonecrosis of the talus was formally suggested as strict non-weight bearing for 36 months. As you can imagine, this is a very difficult treatment regimen to comply with. Now, most people prescribe weight bearing as tolerated in a patellar tendon bearing cast. Weight bearing on a necrotic talus poses no increased risk for collapse as shown by Penny.